really is currently, I would say, controversial. I think it's unquestionable that these saves lives in patients with cardiogenic shock, but the PROTECT 4 study is prospectively evaluating whether or not use of these in chronic stable patients can help improve outcomes. But here's our patient. He's 70 years old. He's dyspnea and fatigue. He's pre-end-stage renal disease. Has actually had a few episodes of hemodialysis, but not too many. And he's got chest pain. He's referred from another institution with multiple coronary lesions, triple vessel disease. He's a sick guy. He's got some pulmonary hypertension, PVD. Okay, that helped. Good. All right, well, here he is. 70-year-old guy, as I mentioned to you, ESRD, sick guy, pulmonary hypertension, on dialysis, EF's 35%. He's got a reduced RV function, no AS, but moderate to severe MR. So a pretty sick guy. And we start off, this is his LV, which is pretty poor, right? And this is a diagnostic coronary angiogram. Circumflex is occluded. The right coronary is occluded. You can see there's collaterals. There's a very high-grade lesion in the left anterior descending that's pretty diffuse. And the right coronary artery is occluded. Now, this patient has a low EF that's viable in every territory. He's got symptoms. I don't know what the culprit is. So the question is, how do you manage this patient? So the plan for this patient was a PCI of the left system using HD-IVUS and the MLD Max algorithm. And our plan was actually to do this with Impella because we knew that if we tackled any of these lesions, there's no bailout. All the other vessels are completely ischemic. So this is a patient with ESRD, calcific disease, a long CTO of the mid-circumflex and the mid-RCA with a planned PCI of the LAD and RCA. So just a little tip on those of you who are not that very familiar with Impella, this is the optimal strategy to place it. Learn from the TAVR group. You actually go in LAO as it crosses the aorta to make sure that the Impella doesn't get stuck, and then come in the RAO, and as soon as you enter the ventricle, you actually pull the wire and the Impella actually gets pulled in. Once you get that, that's the optimal way to minimize the interaction between the device itself. This is the single access technique, so you'll see we have the Impella 14 French sheathis. This is a micropuncture, and we use the micropuncture into the double diaphragm of the Impella in order to get access. And then once we've got access, we use a micropuncture sheath, put that immediately next to the Impella itself, so you can see that they're actually parallel to each other. We switch that out for the Impella stiff sheath or stiff wire, and then we advance a destination pinnacle 45 centimeter with a hydrophilic coating through that so that you actually have the sheath immediately parallel to the Impella itself, and this is what is known as the single access technique. Of course, setup angiography is critical. This is our first shot looking at the left circulation to identify the collaterals. For me, my favorite angle here is a slight RAO with cranial. And so this really shows that there are multiple septals, although significant tortuosity. I haven't really talked about the Impella yet, and that's exactly how it should be. If you're talking about the Impella, it's not doing its job. The job of the Impella is to support the case during your intervention. So we, as was just described in the hybrid algorithm, always our first attempt is to advance antegrade, but there's literally no question here that I'm in the subintimal space. I can feel it. The wire is not advancing, and it gets stuck inside the body of the RCA. Now, so we go retrograde, and we've entered into one of the septals. This is what is known as septal surfing. We're basically looking to see if we can catch something. This is our antegrade, our retrograde crossing. And I'm across. And so while this seems to be the aha moment where you feel very happy, you need to be very careful and check the position of your wire, because you'll notice that the tips of the wires are not actually dancing together. And the way to do this on cine is to do a rotational angiography and realize that although we think this is actually in the body of the right coronary artery, one of these wires is in fact not. When that happens, what you should do is take a retrograde injection to make sure that your antegrade wire actually is where you think it is, and then start looking for other septals. In this example, what I'm going to show you is that we're now picking a different septal, which is the more proximal of the septals. We usually start distal. And what I want to show you in this example is how unpredictable the course of the septal actually can be. This is a Xi'an black wire. You can see it's getting caught up regularly. And while it looks like this is actually going towards the apex of the ventricle, what's very interesting here is that at one point, you'll see that it actually goes towards the apex of the heart, takes what looks like a very uncomfortable turn where many of us would actually stop. This is the point at which you need to put your microcatheter down a little bit in order to get a little bit more support, and then you'll see that the wire actually takes a rather awkward turn, and this is one of the benefits of our very, very high quality wires at this stage, and we end up retrograde. Now, while I got to show you this in about 2 minutes, it probably took about 30 minutes. Right? This is a long, laborious project for us to find the right septal with multiple septal surfing projects, and that's the benefit of the Impella, because you don't have to worry about the patient's hemodynamics during this case. This is your check angiogram to make sure that you actually are where you think you are, and the microcatheter is now being spun through its tortuosity. This is a Turnpike LP and is actually moving fairly well. Now, what I didn't mention to you earlier on was that it was actually quite difficult to advance the antegrade microcatheter down the right coronary artery. And that's because there's a very large intraluminal occlusion with calcification. So now what we're trying to do is get our retrograde catheter up closer towards the rendezvous, so to speak, so that the microcatheters are facing each other. And now we can see that the wires are actually dancing. They're in the same plane, so we are in the architecture of the right coronary artery. Here, now, because I'm still in an ambiguous space, you can see the wires are quite separated. What I'm trying to do is get a retrograde knuckle, and finally I've got a retrograde knuckle, so the retrograde knuckle is sitting right next to the antegrade microcatheter, so this is close enough for me to start to try to perform reverse cart. And here's a reverse cart. So what we're doing in this reverse cart is I've tried to get my microcatheter proximally distal, and my distal retrograde catheter more proximal, but I can't. I'm stuck. And so what we've actually decided to do here in this reverse cart is actually to switch to a Gaia third, use a sharp wire, and do a guideliner assisted reverse cart. And this is one of the benefits which was just mentioned about the Gaia, especially the Gaia second and third, that they will deflect towards the subintimal space, cut through tissue planes, and then you'll see here relatively quickly we're going to be able to actually enter into the retrograde space, somewhere right. And here's the connection coming up. So this is a slow, laborious process. We're getting closer and closer to the guide extension catheter. And now we're right next to the guide, so we know that we're very close. You don't pull back too much. So here I think I'm in, but I'm not. And these are just very small pullbacks to get back in, and now we've made the connection. Okay, so now it's as simple an angioplasty. The first thing we do here is use a 2530 balloon to make ourselves space. We're not taking injections. We get our retrograde microcatheter back forward. And now this is one of the most important parts, and that is to use IVUS. The IVUS marks our distal landing and the amount of negative remodeling. So what you'll notice is I'm actually pulling the IVUS back manually to find the most distal segment that is a normal tissue, and then the lesion, and then I re-advance to a normal segment, and I press cine, which I just did there. That is the landing zone. And this is a still frame showing the landing zone on the angiogram. The fluoroscopy should never move from this place, and this is where we're going to land our distal stent. We do a proximal reference measurement and see that we're about a 4 millimeter vessel, and then what we're going to do here is actually start placing stents. So this is simple drug-eluting stenting, and this is our post-DS IVUS. And so here you can see we landed just before the bifurcation, and this is all done without angiography, without fluoroscopy, with contrast. And we do a simple run, and what I want to do, I know I'm running out of time, is I want to show you this. This is the calcified lesion that we saw earlier that we could not penetrate antegrade, so we went around it, and now unfortunately it's causing significant recoil. So for the sake of time, I'm just going to show you the IVUS post-DS frame. Obviously this is suboptimal, and you can see on the angiogram that the stent is being pushed in from the outside. So what we end up doing is actually performing shock wave on this vessel in order to maximize our gain. We gave all 80 pulses directly into the vessel. This is continuing shock wave, and this is our IVUS final minimal luminary in that segment of 5.13 millimeters, and this is going to be our final IVUS here, and this is our final angiogram. So I think what I've shown you here is I didn't talk about the Impella at all. This was a highly calcified patient, very complex anatomy, very high syntax score, pulmonary hypertension, moderate to severe MR. We didn't talk about hemodynamics at all. That's what the Impella lets you do. It allows you to take the time to surf the septals. It allows you the time to make sure that you aren't rushed, and it makes sure that it allows you to do as complete a revascularization as possible. Thank you very much.